All right, let's jump right in. In this explainer, we're going to tackle some key spinal deformities that are absolutely crucial for your ortho studies. We're talking scoliosis, Scheuermann's disease, and, importantly, how to tell them apart from just plain old poor posture.
Okay, here's our game plan. First, we'll get the lay of the land, what makes these conditions different. Then, we'll really get into the weeds on structural scoliosis, especially its management protocol. From there, we'll pivot to Scheuermann's disease. And then we'll wrap it all up with the high-yield stuff you absolutely need to remember.
All right, first things first, we have to draw a really clear line in the sand between a functional problem, like slouching or poor posture, and a true, honest-to-goodness structural deformity of the spine. They are not the same thing.
So here's the fundamental difference, and it's a big one. Think of poor posture as a software issue. It's about how the spine is functioning, but the hardware, the bones themselves, are totally normal. There's no fixed change. Structural deformities, on the other hand, that's a hardware problem. We're talking about fixed, measurable, anatomical changes to the actual vertebrae. Scoliosis and Scheuermann's fall squarely in this camp.
Okay, let's tackle our first structural problem head-on, scoliosis. And you'll see pretty quickly that it's a whole lot more than just a curvy spine.
Right, so this is mission critical to understand. Scoliosis is a three-dimensional deformity. A lot of people just picture a simple sideways curve, but that's not the whole story. The official diagnosis, radiographically speaking, is a lateral curve of more than 10 degrees. But, and this is the key part, it has to involve both that sideways curve and a rotation of the vertebrae themselves.
And that rotation, that's everything. Clinically, that's what you're really looking for, because it's the rotation that causes all those telltale signs, like the asymmetrical rib cage and the uneven flank muscles that you see on your physical exam. No rotation, no true structural scoliosis. It's that simple.
And this really hammers it home. What's the number one most important clinical sign you need to have burned into your brain? It's that asymmetry, that rib prominence, that paravertebral rib hump. When you have your patient do the Adams forward bend test, that's the money shot. It's the cardinal sign that screams structural scoliosis.
So you've diagnosed it, now what? How do we actually manage it? Well, the cool thing here is that the approach is incredibly structured. It's not a guessing game. It's all based on a single, very specific number from the X-ray.
And that magic number is the Cobb angle. A Cobb angle over 10 degrees, that's your diagnostic line in the sand. If it's less than 10 degrees, we just call it spinal asymmetry. We don't even call it scoliosis. But once you cross that 10-degree threshold, you're in the game.
From there, the management plan is a really straightforward tiered algorithm. It's beautiful, actually. For smaller curves, up to 20 degrees, we're talking physiotherapy. Once you hit that 20 to 40 degree range, we bring out the big guns, bracing. And yeah, we're often talking 23 hours a day. Then, for any curve that progresses beyond 40 degrees, surgery is squarely on the table. You absolutely have to know this algorithm for your exams and, of course, for making real-world clinical decisions.
Okay, let's switch gears. We've been living in the coronal plane with scoliosis, looking at the spine from the front. Now, we're going to pivot 90 degrees and look at the sagittal plane, from the side, to talk about our next condition, Scheuermann's disease.
So what is Scheuermann's? Basically, it's a rigid kyphosis that shows up in adolescence. Kyphosis just means that forward rounding of the spine, right? The key here is that the underlying cause is a structural problem with the vertebrae. They actually become wedge-shaped in the front, and that's what causes that classic rounded back look.
And just like scoliosis has its Cobb angle, Scheuermann's has its own very specific diagnostic criteria. You can thank Sorensen for these. On an X-ray, you're looking for anterior wedging of at least 5 degrees, and it has to be in at least 3 vertebrae right next to each other. This is what separates it from simple postural kyphosis. That's flexible, and it doesn't have these bony changes. Scheuermann's is rigid. Now, how we treat it is a whole different ballgame compared to scoliosis. Remember that super strict angle-driven algorithm for scoliosis? Forget it. For Scheuermann's, the approach is almost always conservative first. We're talking physical therapy, maybe some bracing while the patient is still growing. Surgery is really a last resort, saved only for those really severe progressive cases or when the patient's symptoms just won't respond to anything else.
Okay, we've covered a lot of ground, so let's boil it all down. What are the absolute, high-yield, must-know points you need to walk away with?
All right, here are your 5 big takeaways. 1. Scoliosis is 3D. It's got that lateral curve plus rotation. 2. The rib hump is your go-to clinical sign for it. 3. Managing scoliosis is all about the numbers, specifically the Cobb angle. 4.
Scheuermann's is a rigid kyphosis in the sagittal plane defined by that wedging criteria, at least 5 degrees in at least 3 vertebrae. And finally, 5, treatment for Scheuermann's is almost always conservative first. Got it?
So I'll leave you with this final thought to chew on. We've clearly established that these are two very different structural problems, right? One is a rotational mess in the coronal plane, and the other is a wedging problem in the sagittal plane. So think about it. With those completely different biomechanics at play, how do you think their long-term prognoses might differ? What's the ultimate impact on a patient's spinal health and function down the line?